welcome everybody to this Patient's Perspective Roundtable today, which is titled Sexuality and Cancer. I'm really delighted because we truly have an international group of registrants. So welcome to everyone, wherever you are in the world. We know that a diagnosis of gynecological cancer can have a huge impact on sexuality, relationships, and intimacy, but it's something that we just don't talk about enough. So in today's webinar, we hope that this will help us to learn how to open up lines of communication and provide support and education so we can better address the concerns about sex and sexuality during and after treatment from a gynecological cancer. I'm Dr. Ros Glasspool. I'm the Vice Chair of the Advocacy Committee for the IGCS, and I'm a medical oncologist in the United Kingdom, based in Glasgow in Scotland. And I'm absolutely delighted today to be joined by Dr. Susan Carr from Australia. She's a consultant in sexual and reproductive healthcare and headed the psychosexual service here in Glasgow before she headed for sunnier climes in Melbourne, where she then headed the psychosexual service in Melbourne. She's a past president of Sexual Health Section of the Royal Society of Medicine in London and of the Australian Society for Psychosocial Obstetrics and Gynecology. She's got extensive training and lecturing experience in all topics related to sexuality and has published extensively on the topic. So it's absolutely brilliant. Thank you, Susan, so much for joining me today as we discuss this really important topic. I think just before we got started, I've got a few housekeeping items. So this is being recorded and it will be available on the IGCS Education 360 Learning portal. And we will be having a Q&A session at the end of Susan's presentation. So please do submit your questions during the Q&A. I'm afraid your microphones are muted, but we will be monitoring that Q&A and trying to address as many as possible at the end. And then just before I turn the webinar over to Susan, I'd like to explain a little bit of the background as to why we have put this on today. Earlier in the year, we had a survey, and I'm going to discuss the results of that, where we asked women living with and beyond a diagnosis of a gynecological cancer for one of their main, what their main support needs were, and sexuality-related concerns came very high up the list, and it was very clear that they'd have very little support. So overall, in the survey, we were wanting to see what the needs were of women with gynecological cancer and anyone affected by a gynecological cancer, how those needs differed in different countries, what resources were available, what was useful to people, and then very importantly, what we could do within the IGCS and the IGCAN to support some of those needs. So we sent a survey out, and we really did have international representation. Over 400 people responded from all over the world. It was still largely high-income countries, and that's something that we'd like to address in the future. But nevertheless, we got very good number of respondents, for example, from India, which was great. And we asked many questions, but one of them was was about sexuality-related concerns and what did they struggle with. And I think it was interesting that when we looked at this, only 66 of the patients actually skipped this. So this is still a very important question for people. And I think less than 20% said they had no concerns, with around 50% reporting loss of desire, body image alteration, and sexual dysfunction, also really important issues. So we look at the next slide. I think the quotes that some of the people put in were really very telling, and we really appreciated people sharing this with us, because although there were some of the more physical needs, what we saw was that it was the emotional needs that were really impacting on people, and there was a feeling of loss of self-worth, difficulty with satisfying their husband, problems that brought into their relationship, and again coming through was very strongly was a theme of a lack of support and a lack of sort of opportunity to talk about these issues. So again, just going to the next thing, and here we found that in terms of the numbers of people who were offered support, it was very low, with 11.5% only reporting that they had any support for sexuality-related concerns. And when we asked how satisfied people were with that support, we found that 32% were dissatisfied or very dissatisfied. So we recognized that this was a huge unmet need. And so we wanted to do something, and very fortunate that we have Susan here. And at that point, I'd like to pass things over to you.
Thank you. Thank you. Well, I'm just going to, firstly, I want to thank IGCS for hosting this. I think, as we see, there's an enormous need, and I hope that this is going to be maybe just the start of some more work on sexuality and cancer. Now, what I'm going to do is I'm going to just give you an overview. It's an enormous topic, and I would like to firstly have, could I have my first slide, please, Ashley? That's great. Now, sexuality, sex is not just sexual function. It's not just mechanical. The components of sexuality are what we would call clinically the biopsychosocial sum of its components. That means everything. Part of sexuality is gender identity, who you are. The majority of people identify as male or as female, but as we know, there are a lot of people around the world who identify as something different from that. Sexual orientation, what's that? Sexual orientation is to whom you are attracted. And there are all kinds of varieties of sexual orientation, towards men, towards women, towards both, towards nobody, enormous variation. Then sexual attitudes is really what some attitudes and views on sex that you've been brought up with, and it depends on sometimes culture and society, on yourself, on the people you meet, and also all of that adds up to your sexual behavior. So as you can see from this one slide, sexuality is very, very complex, and it's going to differ from person to person. It's really, there are a lot of similarities amongst a lot of people, but you as an individual will know exactly how things feel to you. Okay, next slide, please. And this is very important, that every individual should be free to express their own sexuality in their own consensual way while respecting that of others. And all sexualities should be equally respected by the healthcare teams. And they should be, and I think that's something you've got to understand and expect if you are thinking of communicating about sex to your treatment team. Okay, next slide. Right, we're talking about sex. Well, it sometimes seems like everybody talks about sex all around the globe. It's everywhere. But is it clinically relevant? And definitely it is. There's a lot of publication about this, but one of the main publications said that key quality of life concerns relate to sexuality. So that's something that clinicians should be aware of and should be able to research, should be able to measure, and to be able to try and improve outcomes for the patients. But as far back as 1868, one of the very, very early sexologists who wrote about sex in a clinical way, Kraft Ebing, said, the most important factor in social existence was sex. Okay, next slide, please. Now, we're talking about gynecological cancer here. So why is sex important, particularly in relation to gynae cancer? Okay, next slide, please. Well, firstly, how common is it? And I thought I would show you these figures just to let you know that if you are feeling problems with sex or sexuality or any aspect of your sexual emotional relationships, you're certainly not alone. Globally, now even people without cancer, in the general population in the USA, 43% of women and 31% of men had problems with sex. A study was done with heterosexual couples, male-female couples. 40% of the women at some point had problems with sex. Middle-aged women in Latin America, 56% of these women seem to have problems with sex. And on our own field, ovarian cancer, a staggering figure of 56.5% reported problems with sexuality. And overall studies is that with all people with cancer, probably about half of them are going to have problems with sex. So it's an enormous problem. And sometimes it's okay, it doesn't help the fact that you've got problems with sex, but it helps to know that there are many, many, many people around the globe who feel the way that you do. Next couple, please. Next couple. Oof, not next couple, next slide. I'm thinking of couples. Right. Women that have had cervical cancer. Studies about, there's been a huge amount of research asking people if they have problems with sex after cancer. And to be honest now, there's so much information about that. It would really be more helpful if a lot of people did maybe a little bit more good research on treatment and what makes people feel better. But people with cervical cancer have got significantly more cancer than people in the same populations without the cervical cancer. Quality of life and sexual function is less, it's compromised. But a little bit of good news is that one study showed that in women who were disease-free after cancer, after treatment, they did not have ongoing problems with sex. Their sexuality and sexual feelings reverted to the way they were before the cancer. Okay, next slide, please. So what kind of physical problems might you have after cervical cancer, as I say, and unfortunately, a lot of you listening to this webinar will know about that. But you get lack of lubrication, vaginal dryness. It's a huge issue. Occasionally, if you've had radiotherapy, short vagina. But interestingly, because of the different mechanisms in the body, orgasm is rarely affected. So in fact, you can sometimes have orgasm without having to have any kind of vaginal penetration. Okay, next slide, please. And now let's look at women with ovarian cancer. And I'm just showing you these figures to show that people have thought about it, have researched it, and they are giving us information. And having clinical information like this helps us guide treatments. So in UK, 63% of the women who were asked about their sex life after ovarian cancer said they had negative consequences. In the US, the same thing. 80% of these women had vaginal dryness, and here we are, we're going back to vaginal dryness. And I think, as an awful lot of you will know, fatigue was a major, major factor, not only in sexuality, but quite often in all aspects of your life if you've had treatment for gynae cancer. But again, we've got a little bit of positive information. In Korea, there was a study which showed that once women felt they were disease-free, then their sexuality was not impaired. So it fluctuates, it will definitely fluctuate. And after endometrial cancer, well, unsurprisingly, a lot of these women felt worse emotionally and sexually before they were treated because they had pain, they had bleeding, they had all kinds of issues. And very often the treatment sorted that out and made them feel a lot better. Of course, they still had problems. And being single, the women who had had radiation therapy, and if they were under 55, they seemed to have a bigger hit with emotional problems. But again, as I said, could be fluctuating, problems could be short-term. Okay, next slide, please. So what we're talking, bottom line, pain on intercourse, which is very physical, loss of interest in sex, causing distress, that is emotional. So back to what we're saying, sex is, there will not be a single cause for a sexual problem. There will not be a single answer in most cases. Okay, next slide, please. So vaginal dryness, we've talked about it. Now, this isn't a gynae talk, but just to run over roughly what's available. You can actually use, studies done with breast cancer and vaginal estrogen showed that there was no negative effects. But as we know, an awful lot of people, both clinicians and people with gynae cancer, really don't want to have any extra hormones. But there are lots and lots of other ways of treating vaginal dryness, not using hormones. You can use lubricants. You can have, and again, it's not only vaginal dryness, vaginal dryness is often caused by menopause, which is sometimes brought on by gynae cancer treatments. So you can use treatments that people would be treated with ordinary menopausal problems. These are all things that your clinician will be able to discuss with you. There was one study done which was very interesting. People talk about laser treatments for vaginal dryness. And a very good study was done and published in 2023 that showed there was no difference between laser treatment and people using very good lubricants to the vagina. So there's all kinds of issues to be discussed. What I do say to you is, if you have or had gynecological cancer, please don't just get something off the internet. Please discuss it with your clinician and make sure it's going to be suitable for you. Okay, next slide, please. And as I say, lots and lots of non-hormonal treatments, lifestyle modification, cognitive behavioral therapy, which is very effective, herbal remedies, acupuncture, medications. New things coming up are called NK3 inhibitors, which are some medications used which act on the hypothalamus in the brain, and they were being used for other reasons. And they discovered that hot flushes seem to disappear for a while with them, but there's no long-term information. And again, any of these things really would have to be discussed with your clinician. Next slide. But here we're talking about the big issue that often isn't faced, emotional relationship issues. You can't just sort it. It may not be caused by cancer. Think about it. It may have been there for some time. The role of the partner. If you didn't really like your partner anymore before you had cancer, you're not very likely to like him any better after the cancer, be the partner, him or her, whoever your partners are. But it needs skilled interventions, as, for example, psychosexual counselling, emotional counselling. And the important thing is that if you have any issue with sex, you should mention it to your clinician. Don't expect the clinician to solve it there and then. Highly unlikely. But if you don't mention it, they won't know about it. Okay, next slide, please. So people want to know what's the best treatment overall for cancer treatment, for sexual dysfunction post-cancer. There's no clear evidence from clinical trials for best option. There are many, many, many options. But whichever option you choose, make sure you've discussed it with your treating clinicians, and as long as the staff you go to are properly trained. Okay, next slide, please. So this is what we're talking about, sexual problem. It's an iceberg. And they say that icebergs are melting, but unfortunately, the amount of sexual problem in the community is not melting the same way. Okay, next slide, please. Now, I just want to give you a story about one of my patients. It's not meant to be a definitive story. It's just to give you an example of how things can be different from what they seem. The story of Maria. Maria and her partner were in their 40s, had 2 teenage children. She had cervical cancer, which at that time was treated with hysterectomy. She'd got the cancer all clear, disease-free, but she had lost interest in sex. And this couple had no problems with sex before the cancer diagnosis. It was really causing a problem in the relationship. Next slide. So she came to the psychosexual clinic and we engaged in consultation. Now, this was not just on one visit. This took 2 or 3 visits to be able to get to what was wrong. She couldn't understand what was wrong. She said she was very, very relieved and grateful to be cancer-free. Her husband had been very supportive and she was very happy with him. She didn't understand why her desire for sex had gone. Then, as we do in the clinic, and I'm a clinician, I offered to examine her. Suddenly she got very upset. She said, no. She said, I don't want to be examined. I'm okay. I'm very well down there. My cancer's gone. No, you can't examine me. And she sat down. I just sat in silence and continued sitting in silence. Eventually, through tears, she told me she'd been sexually abused as a child. She always felt she'd dealt with it. She'd got on with her life, had a good life, hadn't thought about it, but the cancer had made her focus on her genitalia again. And everything flooded back from the past. And she felt awful, and she felt she was being punished from what had happened to her. And as a result, she'd withdrawn from sex. Having understood her feelings then, she was able to engage in positive counselling, and eventually her libido, her interest in sex was improved. So I just use that as an example to show you that cancer can trigger feelings rather than cause them. Okay, we're all clinicians, professionals looking after you, and what is the professional response? And I hate to say it, I used this slide in my first talk 20 years ago, and I'm still using this slide today. The response is that. Next slide, please. Next slide, please. There we are. Communication. Okay, and it's been well studied that although most health professionals think that most women with gynecological cancer have a problem, only 25% of doctors and 20% of nurses discussed it. Now, this first study, and I used this old slide deliberately, 2003, and if you look up any of the studies done 2021, 22, 23, there is no difference. It hasn't improved. Next slide, please. But communication, remember, is a two-way interaction. And yes, somebody has to start the conversation, but also if the clinician does start the conversation, they do need a little help. They can't guess things. So if you really have something that you would like to bring up, if you can, try and help the clinician to help you. Next slide, please. And what I didn't say with the last slide is another huge issue is communication with your sexual partners, partner or partners. Because if you don't communicate with them, then they can't communicate with you and there's a standoff. Right, but in the clinical setting, why is nobody talking about sex? Well, let's look at the patient, which is you. You're embarrassed. Of course, it's very, very hard to talk about it, and we're aware of that. There can be huge barriers, cultural, religious, age. You know, if you're a 75-year-old lady wanting to talk about your sexual difficulty, and you're sitting with a male aged 40, you might find it difficult to breach that barrier, to talk about it. Patients will feel there's no time. It's a busy consultation. There are other patients waiting. I can't take up the doctor's time, but actually you can. And sometimes women will say to me, I didn't want to talk about it. Somebody has really saved my life, and I feel this is too trivial to bring up, but it's not. But let's look at the clinician. Now, I'm not making excuses for them, but how do they feel? A patient brings up sex, and unless it's something that they've been working with a lot, the clinician may be embarrassed. Again, cultural, religious barriers, which stops them from speaking to their patient about it. Same thing, age or gender differences. Time. Clinician knows he's got 50 patients sitting waiting, but time needs to be given to these issues. And also with a clinician, even the most experienced and well-meaning clinicians often don't know where to send somebody, don't know how to help them. And the clinicians do not need to know everything, but they need to be upskilled in knowing where the local resources are. And as you all know, you're listening from all over the world, resources will be maybe non-existent. If they are existent, they'll be completely different from country to country, from town to town. So there are huge barriers about talking about sex. Okay, next slide, please. So just to finish up now, because we want to hear from you, sexual health care is actually a human right. It's not an optional extra. The patient has rights to be able to express their sexuality in a consensual way, and I always say consensual. You have to be in agreement with whoever you are having sex with, or whoever you want to have sex with, and the clinician has a duty of care to facilitate sexuality within the functional ability of their patients. Next slide, please. And remember, keep your mind open, everything's different. People have ways of expressing sexuality, intimacy, fun, and happiness in different ways. Next slide. So to finish up, not much has changed in terms of communication and sex. So what about the future? Well, patient power is strong, is very strong. And one of the areas that patients ask for are peer groups, to be able to discuss these issues with people who are experiencing the same as themselves. These patient power needs to advocate for more and better clinical training in the field, in service design, and setting up good clinical trials of treatment. Of course, you can't do it all on your own, but the patient voice is a very, very powerful one. And IGCS is a powerful organization that can facilitate this. Next slide, please. There you are. I hope I haven't confused you. I know there'll be a lot of unanswered questions, and we're looking forward to hearing what you'd like to talk about. Thank you very much for listening.
Thank you, Susan, very much for that excellent presentation. Absolutely raising so many really, really important issues. I urge everyone, do put your questions in the Q&A. We have had one question that's come in, and absolutely agreeing with you here about urging healthcare providers to initiate discussions about sexuality as part of holistic care. And I think that is really important. I think it's something that we're seeing a huge need for survivorship care plans, as people transition out of treatment. And I think this has to be an element, and that's probably a good opportunity at that point to discuss it. But there was a more specific question, which was, are you aware of any patient-reported outcome measures that could be used to help assess any interventions or any sort of treatments following somebody raising issues of sexual concern?
There are actually there are quite a few validated questionnaires which are used, and often they are very good, but sometimes I feel they do. To me, the best sexual outcome studies are the ones that use some validated questionnaires to get the more technical specific stuff, like how often are you having sex, or is it painful? But it should always be joined on with some more sociological type research of actually letting patients talk, hearing some stories, and analysing that in a professional way, because the numerical questionnaires just don't capture very often how somebody's feeling, and that's so essential in sexual health research.
And you were mentioning about the sort of lack of resources, and I know that is often a concern for clinicians, that you might start a conversation and open up issues and then feel that you can't adequately address them in the time that you have or with your expertise. But I know that you had mentioned that you'd set up a telephone counselling service at one point, and just wondered if you could elaborate a bit on that experience.
That's right, because we're very well aware that it's all very well to talk about counselling and groups and things, but some people live in very, very remote parts of the globe or very remote parts of their own country. And in Australia, we tried to address this by having sexual counselling by telephone, and patients actually made formal appointments, and we were able to speak to people, to support people and give them proper counselling over the phone, which didn't used to be done before. There's always a training that you have to be able to sit with the patient and observe them and interpret that back and in a reflective way. But we used and we spoke to a lot of people who were, this was in Australia, who were very remote. They could be 2,000 miles from the nearest main treatment centre. And it gave them wonderful support. It felt very intimate in a very professional way and very private, speaking one-to-one. The appointments were booked so that the patient could make sure they were somewhere where they were not going to be disturbed. And it was evaluated and it was found to be extremely effective. Unfortunately, as with so many of these things, the funding disappeared and it doesn't exist anymore. And also, I wonder, Roz, if you felt I was being a bit hard on the clinicians about not answering, not doing, putting their hands over their eyes.
I don't think you're being hard on the clinicians at all. I think I'm aware that, it's not an issue that we tend to raise unless somebody raises it with us. And I think you're absolutely right to encourage people to do that and not to feel that they can't do that. I think it's something that we should be looking at actually in terms of education, both for physicians, but also for our nurse specialists. So to give people the confidence so that they can open up the conversation themselves and address it. I think there's always that worry people have of starting it and causing offence or making the wrong assumptions. But I know, well, we've talked about it as well, that people often will make assumptions about people's age and whether they're whether sexuality is still an issue, and that is absolutely a very dangerous thing to do, because we know that sexuality is very important at all ages. But I don't know if you feel that you have extra things to comment on, but I think I can understand why young trainees are maybe not that comfortable at asking older people about whether they have issues with sex.
It's a huge issue. I mean, it's all very well to say, talk about it, mention it, but it's very, very hard. The barriers are huge. The barriers can often be just things that you don't think about. A lot of people, when they come to a cancer consultation, will have a support person with them. Now, that might be a mother or a daughter or a brother or somebody else. And these are people with whom they would not want to open up sexual conversations. So really to be able to give the patient a chance, or even to say, look, there's something I'd like to ask you, and to say to the support person, would you mind waiting outside for a few minutes? Now, it's not easy to do that, but these are things that are so happen every day. And then people will come out of the consultation and say, I wish I'd said something. But always do. And as I say, the clinician can deal with it very quickly, can just say, I'm not sure at the moment, I don't have an answer for you, and I will get back to you, and do that. But also the clinical parts that we talked about, things like the vaginal dryness, the pain, these are issues that your clinician should and will probably be very happy to deal with. It's often the more emotional element that is hard. It takes time and it takes training to be able to deal with it.
Absolutely. I think that's where knowing where to signpost people to get that sort of support, because that's realistically not going to happen in a clinic. But as you say, if we don't know, we can't start. There's a couple more questions that have come in. So I think it's Dr. Yan, working as a radiation oncologist in a part of the world with many different cultural and social backgrounds, where, and just really commenting that cultural barrier is a big issue. And I think that's, again, an area where people are sensitive about making a mistake. And I think, well, we're hoping, and I'll come back to it at the end, we want to reach out to our IGCAN network to try to gather resources that are culturally sensitive in different languages, where people can look for support, very much provided by people from their own backgrounds. So I think anyone who can help us with that would be very valuable.
I think it would, but as I say, to reiterate, the patients themselves, the women themselves, have got tremendous power and tremendous ability to help each other. But an issue which is often overlooked is partners. And sometimes the partners feel at an absolute loss, and they're not used to speaking about issues. If the partner is female, it's in some ways easier because they find it easier to communicate. But if the partner is male, then they find it very hard. And I've facilitated in Australia several groups of males only, male partners. And for about the first 10 minutes, they sat in a circle and nobody spoke. And they were too embarrassed. And then once somebody started to say how they felt, obviously distressed at their partner's illness, but they felt illogically sometimes guilty. Sometimes they didn't want to have sex because they were frightened of hurting the person or reinfecting her. So partners also need to have support should they request it, or should the patient request it for her partner.
Yeah, I think that is a huge issue, that we have to involve partners as well. So there's another question asking about whether there are any available sort of treatment and therapy guidelines for clinicians who are wanting to provide patients with best care for sexual function and libido. I know there are guidelines in terms of helping to manage menopause and in hormone-sensitive cancers, but I'm not so aware of guidelines in terms of helping with sexual function. I don't know if you're aware of any.
Well, they would be different again, they're not as many, obviously, and sometimes it's been very hard to evaluate the more sort of almost psychotherapeutic type of interventions. But with the more practical ones like CBT, cognitive behavioral therapy, there should be measures, but it depends on what country you're in, the professional body. I mean, look at medical bodies, look at the clinical psychologists or people who will do that sort of work. The trouble with a lot of sexual or sexology or sex specialists is in a lot of countries it's pretty unregulated. And that's another thing I think you have to look at, is if you are going to go to somebody, make sure they're properly trained, properly professionally supervised and qualified.
Absolutely. And then there's another question is, do you think they'll ever make another questionnaire that will allow the patient or survivor to answer questions about sexual dysfunction and let their clinician look over it and discuss it at another appointment? Well,
that's a wonderful idea. And that would be, you know, in certain measures, it's done a lot that people have to fill in forms before they go and then it's discussed. But sadly, it can be almost more often done in something like the hairdressers, you know, because they want to make sure you're not allergic to any products, and you fill in a questionnaire and discuss it. And that's a very, very helpful tool. Just something that's not a research questionnaire, but something practical, so that people will not have to bring the topic up cold, but it will be there on the sheet of the paper and they can highlight it if they want to talk about it. Excellent idea.
Yeah, and it's something that could very much be incorporated into a survivorship plan, where, you know, different issues can be opened up. Yeah, the priorities for that particular individual patient. So I think that is a really good idea that we should explore, in terms of if we're trying to develop some templates for people that can be used and adapted around the world, that we make sure that the sexuality is included as a component of those. And then again, so I'm just really raising that this is a huge quality of life issue. This is Dr. Lawal, I think, and often buried in silence, especially in cultures where discussing sex is a taboo subject, and it needs to take prominence along with all the other aspects of care. So I completely agree with that comment. So thank you. And that's really what we want to do. And I realised that we've run over our half an hour. So I really wanted to thank Susan again for her time today. I also want to thank the women who completed the survey, and to say that, you know, we are listening to what people said and hoping to act on them. We realise that this is really just the beginning of the work that we need to do in this area. And we want to look at other topics that we can continue in this theme as further webinars. And as I said earlier, we'll also be reaching out to people within the advocacy network, asking for any resources that you're aware of in your country, or culture, things in different languages. I've been putting together some things that I'm aware of from the UK, but we want to make this truly international because this is a problem everywhere. And thank you very much. Somebody's put something in the Q&A already, so that's fantastic. So at that point, I think I will draw it to a close. Wish everybody continued health and safety, and huge thanks for your time and for attending today. Thank you very much.
Thank you.